When a manifest deviation of the visual axis is present, images of objects are shifted onto the retinas. The larger the shift, the greater the deviation. When fusion became impossible, two distressing results occur. First, different objects are imaged on the two foveae, and therefore are seen in the same visual direction and overlap. This phenomenon is termed confusion. Second, two identical objects are imaged on disparate retinal areas, the fovea of one eye and the peripheral retina of the other eye, and therefore, the two objects are seen in different visual directions, that is, they are seen double. This phenomenon is termed diplopia. Mechanisms to avoid diplopia and confusion are suppression and anomalous retinal correspondence. Suppression is defined as the inhibition of the confusing image originating from the retina of the deviated eye. Anomalous retinal correspondence is binocular sensory fusion of the fovea of the fixating eye and the non-foveal retinal area of the deviated eye to permit a single binocular vision. The most common causes of monocular diplopia are changes in the lens, anomalies of the tear film, the cornea and the vitreous, pressure of the upper lid on the cornea, brain trauma and in cerebrovascular accident. Monocular diplopia disappears when the patient looks through a pinhole. In binocular diplopia, a red glass test will determine its type. In esotropia it is uncrossed or homonymous diplopia. In exotropia it is crossed or heteronymous diplopia. In hypertropia or hypotropia it is vertical diplopia. Finally, in cyclotropia it is torsional diplopia. Suppression may be monocular suppression in uniocular heterotropia, or alternating suppression in alternating heterotropia. Perimetry can be done with any type of haploscopic devices with the use of color differentiation, such as red-green spectacles. This permit monocular and alternating suppression to be detected. In strabismic patients who has monocular fixation, scotomas are found in the deviated eye, but in patients who has alternating fixation, scotomas are found alternately in the two eyes. Perimetry can be done with any type of haploscopic device that allows scanning of the retinas to detect the presence of scotomas. Similar findings were reported by the screen and mirror arrangement of Travers for the mapping of suppression scotomas in strabismus. By using prisms, one can estimate the extent of a suppression scotoma. By placing prisms of increasing strength in front of the eye, one will find a prism with which the patient reports diplopia. Now, the image of the fixation point is thrown out of the region of the suppression scotoma onto a retinal area that is not suppressed. The power of the prism required to produce diplopia is a measure of the extent of the suppression scotoma. A more effective test for foveal suppression is to measure the visual acuity of each eye under binocular conditions with the projecto chart slide. A decrease of visual acuity of one eye that is not present when the eye is tested under monocular conditions will indicate foveal suppression. Suppression can also be diagnosed with the Worth 4-dot test. In normal fusion, the patient sees the all 4 dots. In normal retinal correspondence, if the patient sees only the 3 green lights from the left eye, this is right suppression. If he sees only the 2 red lights from the right eye, this is left suppression, and if he is switching between seeing 2 red lights or 3 green lights, this is an alternating suppression. If he sees 5 lights, the red lights may appear to the right, as in uncrossed diplopia with esotropia, or to the left of the green lights as in crossed diplopia with exotropia. To make a patient aware of the suppressed image of the deviated eye, one must reduce the retinal illuminance of the fixating eye by using red filters ladder until the patient sees double. The greater the number of the filter needed, the deeper the suppression. Patients with 30 to 40 prism diopters of esotropia may make use of the blind spot mechanism to avoid diplopia, by putting the visual image of the deviated eye onto the blind area of the optic disc. The red filter test. In normal retinal correspondence with normal fusion, the patient can see the red and the white image superimposed. Heterotropic patients with a normal retinal correspondence can see two lights, a red one and a white one. In esotropia the images appear in homonymous uncrossed diplopia. In exotropia the images appear in heteronymous crossed diplopia. Patient with anomalous retinal correspondence, single binocular vision occurs in the presence of a manifest strabismus. To distinguish between suppression and anomalous retinal correspondence, a vertical prism is placed base up before the deviated right eye. In the case of suppression the prism will move the white image below and to the right of the red image. In the case of anomalous retinal correspondence, the white image appears directly below the red image. Afterimage test is performed by using a battery-powered camera flash to produce a vertical afterimage in one eye and a horizontal afterimage in the other eye. The resulting afterimage is that of a line with a break in its middle, which represents the fovea. If the vertical afterimage with its central hole appears to cross the center of the horizontal afterimage, this implies that there is normal retinal correspondence. But, if the vertical afterimage with its central hole appears to the left or to the right of the hole in the horizontal afterimage, this implies that there is anomalous retinal correspondence. Striated glasses of Bagolini. In normal retinal correspondence with normal fusion, the patient can see two streaks crossed in the center. If the patient with manifest deviation reported two streaks crossed in the center, then anomalous retinal correspondence is present. If the patient reported only one streak, then suppression is present. If the patient reported two streaks separate from each other or crossing in the peripheral part of the streaks, then diplopia is present. If the patient reported one line, then the lines switch and they can only see the other line, then an alternating deviation is present. Testing with the major Amblyoscope. If normal correspondence exists, the images of two dissimilar targets appear to be superimposed. In the presence of anomalous retinal correspondence and if the patient is esotropic, there will be crossed diplopia. If the patient is exotropic, uncrossed diplopia will occur.